Ischemic heart failure, treating the cause, not just the syndrome. With an illustrative case study of severe multivessel coronary disease. Introduction. Heart failure, HF, is a final common clinical syndrome resulting from diverse upstream pathologies. Among them, ischemic heart failure, ischemic cardiomyopathy, is the most prevalent and prognostically significant. 1. While modern guideline-directed medical therapy, GDMT, targets neurohormonal remodeling, optimal management of ischemic HF requires simultaneous treatment of the underlying coronary disease. 1. 2. Aspirin is often described as not treating heart failure itself, which is technically correct but clinically incomplete. In ischemic HF, aspirin addresses the causal ischemic substrate, helping prevent further irreversible myocardial injury. 3.8. This article clarifies the role of low-dose aspirin in ischemic heart failure, delineates its limits, and presents a real-world case illustrating its appropriate use within a broader therapeutic framework. Ischemic heart failure, pathophysiology and therapeutic layers. Ischemic heart failure results from obstructive coronary artery disease, CAD, 1. Repeated overt or silent myocardial infarctions, 1. Chronic myocardial ischemia leading to fibrosis and remodeling, 1, 2. Once left ventricular dysfunction develops, two parallel disease processes drive progression. 1. Upstream ischemic injury. Plaque rupture. Platelet-mediated thrombosis. Flow-limiting stenosis, 3.8. 2. Downstream neurohormonal remodeling. RAS activation. Sympathetic overdrive. Aldosterone-mediated fibrosis, 1, 2. Effective management requires both layers to be addressed. 1. Additional upstream ischemic contributors, hyperviscosity and polycythemia. Although obstructive coronary artery disease is the dominant driver of ischemic heart failure, myocardial ischemia ultimately reflects impaired oxygen delivery rather than luminal stenosis alone. Hemorrhagic abnormalities, particularly hyperviscosity states such as polycythemia, represent an often underrecognized upstream contributor to ischemic myocardial injury, 10 to 12. Polycythemia, whether primary, e.g., polycythemia vera, or secondary, e.g., chronic hypoxemia, smoking, erythropoietin excess, increases blood viscosity in a nonlinear fashion as hematocrit rises. 10, 11. Elevated viscosity impairs coronary microvascular flow, increases coronary resistance, and reduces effective myocardial perfusion, especially in patients with limited coronary flow reserve due to multivessel coronary disease or left ventricular systolic dysfunction. 12, 13. Consequently, myocardial ischemia may develop or worsen even in the absence of acute plaque rupture or critical epicardial obstruction. A patient can have non-obstructive coronary arteries on CT yet still experience severe myocardial ischemia, because ischemia reflects impaired blood flow rather than anatomical narrowing alone. Coronary CT angiography, CCTA, effectively visualizes plaques, calcium, and large vessel stenosis but does not assess microvascular function or coronary flow reserve, CFR, which are critical determinants of myocardial perfusion. In conditions such as ischemia with non-obstructive coronary arteries, INOCA, impaired CFR or elevated microvascular resistance can produce objective evidence of ischemia on functional testing despite the absence of significant epicardial obstruction on CT or angiography. Detection of this functional ischemia may require stress testing with perfusion imaging, cardiac PET or MRI, or invasive physiological testing of CFR and microvascular resistance, as recognized in contemporary clinical recommendations for evaluation of suspected INOCA, 17-18. Beyond flow impairment, polycythemia is associated with a prothrombotic state characterized by platelet activation, leukocyte, platelet interaction, endothelial dysfunction, and increased arterial thrombosis risk. 11-14. These mechanisms predispose patients to type 2 myocardial infarction, supply-demand mismatch, silent myocardial infarction, and progressive myocardial fibrosis, thereby accelerating the onset and progression of ischemic cardiomyopathy. 12-15. Importantly, antiplatelet therapy alone does not correct hyperviscosity-mediated ischemia. In patients with ischemic heart failure and concomitant polycythemia, truly cause-directed management requires normalization of hematocrit, typically targeting less than 45% in polycythemia vera, treatment of the underlying driver of erythrocytosis, and careful avoidance of excessive diuresis that may further increase blood viscosity. 10-11-16. In this setting, antiplatelet agents serve as adjunctive secondary prevention rather than definitive therapy for the ischemic mechanism. Recognition of hyperviscosity as an ischemic substrate reinforces the broader principle that optimal management of ischemic heart failure requires identification and treatment of all upstream contributors to impaired myocardial oxygen delivery, beyond atherosclerotic plaque burden alone. Mechanism and role of antiplatelets, aspirin versus clopidogrel. Low-dose aspirin, 75 to 100 mg daily, irreversibly inhibits platelet cyclooxygenase 1, COX-1, reducing thromboxane $A_2 mediated platelet aggregation. 3-8. What antiplatelets do? Reduce risk of myocardial infarction and ischemic stroke. 3. Prevent thrombosis on unstable coronary plaques. 3-8. Preserve remaining viable myocardium. 3. The prostaglandin conflict, a clinical debate. Historically, aspirin has been the cornerstone of secondary prevention in coronary artery disease, CAD. However, a significant nuance exists in the context of heart failure. Aspirin inhibits cyclooxygenase, which reduces the production of prostaglandins, $PGE_2 and $PGI_2. These prostaglandins are vital for maintaining renal blood flow and modulating the renin-angiotensin-aldosterone system, RAS. 3-6. The theoretical interference. There is a long-standing concern that aspirin may theoretically blunt some of the vasodilator and renal protective benefits of GDMT, specifically ACE inhibitors and ARNIs like Entresto. 4-6. Some studies have noted a transient rise in NT-proBNP or a reduction in the first-dose benefit of ACE inhibitors when high-dose aspirin is present, though the clinical impact of low-dose aspirin, 75 to 100 mg, is less clear. 2. The guideline view. Currently, major heart failure guidelines, AHA/ACC/HFSA 2022, remain neutral, viewing aspirin and clopidogrel as equally acceptable for secondary prevention in ischemic HF. They do not yet mandate a preference for clopidogrel based solely on the HF syndrome. 3. The emerging practice. Many clinicians are shifting toward clopidogrel, 75 mg, for long-term maintenance in ischemic HF. This is supported by the HOST exam trial, which demonstrated that clopidogrel monotherapy was superior to aspirin in reducing a composite of adverse clinical events, including MI and stroke, in patients who have stabilized after coronary stenting. 1-6. The bottom line, in high-risk cases, like our patient with left main equivalent disease, the priority is ensuring any potent antiplatelet is on board to prevent a catastrophic event. In the presence of advanced HF and renal sensitivity, clopidogrel offers a compelling, cleaner profile by avoiding prostaglandin inhibition. 2-6. What antiplatelets do not do. Improve left ventricular ejection fraction, $EF. 3. Reverse myocardial fibrosis. 3. Modify heart failure remodeling. 3. Replace heart failure disease modifying drugs. 1-2. Evidence-based indications for aspirin in heart failure. Clearly indicated, secondary prevention. Documented coronary artery disease, 138. Prior myocardial infarction, recognized or silent, 1-3. Prior ischemic stroke or TIA, 1-3. Prior coronary revascularization, 1-3-9. Not routinely indicated. Non-ischemic cardiomyopathy, 1. Heart failure without documented CAD, 1. Primary prevention in low-risk individuals, 3. Patients already on full-dose anticoagulation, unless otherwise indicated, 1. Clinical recommendation: in ischemic cardiomyopathy, clopidogrel is an increasingly preferred clinical strategy over aspirin to complete optimal therapy. It provides robust secondary prevention of MI and stroke while theoretically better preserving renal function and the efficacy of GDMT pillars, 1-6. This is particularly important for patients with high-risk anatomy, LM equivalent disease, who are prescribed ARNI therapy. Coronary artery anatomy. Understanding which artery is affected helps patients grasp risk, treatment options, and prognosis. Abbreviation. Name. Function/importance. LM. Left main coronary artery. Main trunk supplying most of the heart, blockage here is high risk, 1-9. LAD. Left anterior descending. Supplies front pumping muscle, widowmaker or major pumping artery, 1-9. LCX. Left circumflex artery. Supplies side and back of left ventricle, 1-9. RCA. Right coronary artery. Supplies bottom of heart and electrical system, 1-9. Other terms. Proximal, closer to the artery origin, higher risk if blocked, 9. Stenosis, narrowing due to plaque buildup, 9. Triple vessel disease, significant blockage in all three major arteries, 1-9. Left main, equivalent, severe blockage of the left main or severe proximal disease in both LAD and LCX, 9. Case study, severe ischemic cardiomyopathy. Patient profile. EF is almost equal to 20%, 1. Current HF therapy, Entresto, beta blocker, spironolactone, Jardiance, rosuvastatin 10 mg, 2. Diagnostic findings, CCTA with FFRCT. Left main, LM 50 to 60% stenosis, FF 0.76, hemodynamically significant, 7. LAD, greater than 95% proximal and midvessel stenosis with severe calcification, 7. LCX, greater than 90% proximal stenosis, 7. RCA, extensive plaque, flow-limiting disease could not be excluded, 7. Calcium score, 1008, 98th percentile, 7. A score above 400 indicates extensive plaque burden and a high risk of coronary events. Clinical interpretation. Pattern, left main, equivalent triple vessel coronary artery disease, 1-7-9. Significance, confirms ischemic cardiomyopathy, chronic ischemia plausibly explains EF is almost equal to 20%, 1-2-7. Implication, antiplatelet therapy is now clearly indicated as secondary prevention, 3-8. Therapeutic considerations and medication summary. For this patient, therapy is twofold. 1. Heart failure-directed therapy, GDMT. Entresto improves $EF, reduces mortality, 1-2. Beta blocker, slows heart rate, improves survival, 1-2. MRA, spironolactone reduces fibrosis and mortality, 1-2. SGLT2I, Jardiance improves HF outcomes, 1-2. 2. Ischemia-directed therapy, secondary prevention. Statin, rosuvastatin 10 mg, should be optimized to high intensity to target LDL-C less than 55 mg per deciliter. 1. The goal is not just lowering cholesterol, but plaque stabilization to prevent the ruptures that lead to MI. Antiplatelet, currently missing, indicated to prevent MI in stroke. 3.8. Updated medication table. Drug class. Example. Purpose. Status. RNI. Entresto. EF improvement, survival, 1, 2. On therapy. Beta blocker. Carvedilol. Mortality reduction, 1, 2. On therapy. MRA. Spironolactone. Antifibrotic, 1, 2. On therapy. SGLT2I. Jardiance. HF outcome improvement, 1, 2. On therapy. Statin. Rosuvastatin. CAD stabilization, target LDL-C less than 55, 1. On therapy. Antiplatelet. Clopidogrel, 75 mg. Secondary prevention of MI/stroke, 3.8. To be added. Monitoring antiplatelets, effectiveness versus safety. 1. How we know it is working. Aspirin/clopidogrel prevent clots. While platelet function tests, Verify Now, LTA, can measure efficacy, routine testing is not recommended and does not predict clinical outcomes. 2. How we assess bleeding risk. Bleeding risk is assessed clinically, history of ulcers, older age, greater than 75, and concurrent medications. Laboratory tests cannot tell if a dose is too high, clinical judgment is required. Conclusion: integrated management. In patients with ischemic heart failure, antiplatelet therapy is a cause-directed preventive therapy targeting atherosclerotic disease rather than heart failure remodeling. 3.8. Secondary prevention is mandatory. Once obstructive CAD is documented, antiplatelet therapy, secondary prevention, is essential. Contemporary evidence supports clopidogrel as a preferred option for long-term monotherapy in chronic ischemic syndromes. 1.6. Aspirin/clopidogrel complements GDMT. It must be used in conjunction with the 4 pillars: RNA, beta blocker, MRA, and SGLT2 inhibitor. 1, 2, 4, 5, 6. High-risk anatomy management. Patients with high-risk coronary anatomy, left main plus multivessel disease, EF 20%, require urgent evaluation for revascularization, the process of restoring blood flow to heart muscle that is currently starved of oxygen due to severely blocked arteries, ischemia. CAB remains the surgical standard for improving survival in this cohort. 5.9. ICD timing. ICD implantation is typically delayed until 40 days post-MI or 90 days post-revascularization/GDMT to allow for potential EF recovery. 7. Glossary of terms. CAB, coronary artery bypass grafting, open heart surgery to bypass blocked arteries. Coronary artery disease, CAD, narrowing of the arteries supplying blood to the heart. Ejection fraction, EF percentage of blood pumped per beat, normal, 55 to 70%. FFRCT, a CT-based measurement where numbers less than or equal to 0.80 indicate significant blockage. GDMT, a group of medications proven to improve survival in heart failure. Ischemic cardiomyopathy, heart muscle weakness caused by blocked coronary arteries. Revascularization, restoring blood flow via surgery, CABG, or stents, PCI. Silent heart attack, muscle damage that occurs without obvious symptoms. References.